What a stroke looks like the day before it hits. Know this to protect yourself. The stark reality of stroke is a global health crisis that often goes unappreciated until it strikes a loved one or oneself. Every single minute counts. Every moment carries potential consequence. It is a sobering thought that every 40 seconds, somewhere across our vast planet, an individual is afflicted by a stroke. This means that by the time one has merely finished reading this very sentence, another human brain has tragically sustained damage. On an annual basis, stroke claims the lives of nearly 6 million people worldwide, a devastating toll that positions it as the second leading cause of death globally. Furthermore, and perhaps even more profoundly impacting daily life, it stands as the number one reason individuals are left grappling with permanent disability, irrevocably altering their lives and the lives of their families. Yet, despite these alarming statistics and the profound impact of stroke, there remains a critical piece of information that is often not communicated with sufficient clarity or urgency. In a vast number of instances, the brain itself provides very specific, unambiguous warnings, sometimes hours or even days before a major stroke event takes place. The key then lies not in the unpredictability of the event, but in understanding precisely what these crucial warning signs look like, how to interpret them, and how to act upon them swiftly and decisively. This knowledge is not just medical trivia. It is a vital tool for self-preservation and the protection of those we care about. The widespread perception of stroke often conjures images of sudden, catastrophic events where a person is perfectly fine one moment, then collapses, only to awaken later in a hospital bed, the damage already done. However, this dramatic portrayal, while sometimes accurate, frequently misses a fundamental truth. In the vast majority of cases, a stroke is not an unpredictable act of fate or an isolated incident. Instead, it represents the predictable culmination, the unfortunate endpoint of a gradual process where blood vessels have been silently and progressively degrading over many years. If a condition or an event is predictable, then by its very definition, it is at least partially preventable. This profound insight forms the foundational premise of this discussion, underscoring the critical importance of recognizing warning signs and understanding the underlying mechanisms of vascular health. When people generically refer to a stroke, they are in fact often talking about two fundamentally distinct types of events that can occur within the brain, each with its own specific mechanism and consequence. The first type is known as a hemorrhagic stroke. This occurs when a blood vessel within the brain or on its surface suddenly ruptures or bursts. When this happens, blood spills out into or around the delicate brain tissue, forming a clot or hematoma. This clot then exerts intense pressure on the surrounding brain tissue, compressing it and disrupting its normal function. Hemorrhagic strokes are often particularly severe, and tragically, a significant number of patients who experience them do not survive. The second type, and the one we will primarily focus on due to its prevalence, is an ischemic stroke. In this scenario, a blood vessel does not tear or burst. Instead, it becomes blocked, often by a blood clot. When blood flow is interrupted to a specific part of the brain cells in that affected region are deprived of oxygen and vital nutrients. Without this constant supply, these incredibly delicate and demanding cells begin to die, and this process starts remarkably quickly, often within a mere 4 to 6 minutes of the blood flow cessation. Ischemic strokes account for approximately 85% of all stroke cases, making them by far the most common type. Understanding the mechanics of ischemic stroke, therefore, is paramount for effective prevention and timely intervention. To truly grasp the critical importance of every passing minute when a stroke is suspected, it is essential to appreciate just how remarkably demanding your brain actually is. Despite its relatively modest size, your brain is an extraordinary metabolic powerhouse. Weighing in at roughly 1.4 kilograms, it constitutes only about 2% of your total body weight. Yet, this small percentage belies its enormous energy requirements. Astonishingly, it consumes around 20% of all the oxygen you breathe in, and an even more significant 25% of all the glucose, sugar, that circulates throughout your bloodstream. Your brain functions as the ultimate control center, orchestrating every thought, movement, and sensation. And unlike other organs, it never truly turns off. It requires an absolutely constant and uninterrupted supply of fuel. Even a brief interruption, cutting off that vital fuel line for just a few minutes, initiates a cascade of cellular death in ways that are often irreversible. This is precisely why medical professionals emphatically state that stroke is a race against time. It is a literal, desperate race to preserve as much precious brain tissue as possible before it is permanently lost, leading to debilitating and lasting consequences. Every second of delay can mean the difference between a full recovery and a life profoundly altered by disability. What many people fail to fully comprehend is that for a brain artery to suddenly become blocked, the groundwork for such an event typically has been laid over many years, silently and progressively. The walls of the blood vessels, particularly the arteries, have often been damaged, weakened, and scarred over time. Fatty deposits, known as plaques, have been steadily building up, along with the accumulation of cellular debris and small clots. This gradual accumulation leads to a progressive narrowing of the artery's inner opening, much like a pipe gradually becoming clogged. This is not some instantaneous explosion out of nowhere, but rather the final critical step in a prolonged and insidious pathological process. Along this winding road of vascular degradation, your body frequently sends out subtle yet crucial warning signals. The profound challenge, however, is that most individuals have simply never been taught how to accurately read or interpret these vital messages. These early warning shots, which can be thought of as mini-strokes, are medically referred to as transient ischemic attacks, or TIAs for short. The term transient is key here, meaning temporary or fleeting. These episodes come and go, often resolving on their own within minutes, yet their transient nature makes them dangerously easy to dismiss. Picture, for a moment, a carotid artery, one of the main arteries located in your neck. These crucial vessels are responsible for carrying oxygen-rich blood directly from your heart up to your brain. Over the course of many years, often influenced by lifestyle factors and genetics, a fatty plaque begins to form on the inner wall of this artery, frequently at points where the artery branches, as these are areas of increased turbulent blood flow. This plaque slowly but steadily narrows the opening of the vessel. Then, at some critical juncture, the already constricted artery might go into a brief, temporary spasm. Alternatively, a small piece of the plaque or a tiny blood clot that formed on its rough surface might momentarily break off and travel further up the vessel, briefly lodging and blocking blood flow. During this temporary interruption, which may last only a few seconds or a few minutes, the specific area of the brain supplied by that particular artery is effectively blacked out due to the lack of blood flow. You might experience a sudden, startling stroke-like symptom, perhaps a temporary loss of vision, a fleeting numbness, or a momentary difficulty speaking. But then, just as suddenly, the spasm relaxes or the small clot dislodges and drifts away, blood flow returns, and the symptom quickly fades. At this point, it is incredibly common for people to rationalize the event, thinking to themselves, "Oh, I'm fine again. It must have been nothing serious." This is a perilous misinterpretation. What extensive medical research unequivocally demonstrates is that a transient ischemic attack, TIA, very often serves as a direct precursor to a more major ischemic stroke. This relationship is not merely coincidental. These mini-strokes typically occur within the subsequent 72 hours preceding a full-blown stroke. This window of approximately 3 days after a TIA is a profoundly critical period, a genuine opportunity where proactive medical intervention can still avert the impending disaster. Regrettably, the majority of people fail to utilize this vital window. The fleeting and unusual nature of the warning episode, its brevity, its strange presentation, and its rapid resolution leads individuals to talk themselves out of taking it seriously. These warning episodes are indeed often short-lived, typically lasting from as little as half a minute to perhaps 10 minutes at the absolute maximum. This very brevity is precisely why they so frequently slip through the cracks of awareness and concern. One might be engaged in routine activities, preparing a meal in the kitchen, showering, or getting out of a car, and by the time they pause to fully process what just occurred, the symptom has already completely passed. However, each and every one of these seemingly minor episodes is, in fact, your brain sending an urgent, final, and unmistakably clear message: I am on the verge of serious trouble. Recognizing this message and acting upon it immediately is paramount for preventing life-altering damage. To empower you with this crucial understanding, let's delve into the 5 major red flags, the key warning signs that your brain might be in imminent danger. For each, we will not only describe what these signs look and feel like from your perspective, but also what is intrinsically happening within your body when they occur. The first of these vital warning signs is a temporary loss of vision, specifically affecting only one eye. You might be going about your day, perhaps getting up from a chair and walking towards the kitchen, when suddenly the vision in one eye becomes completely dark or intensely foggy. It can feel as if an opaque black curtain has been abruptly pulled down over that eye, or as though someone has smeared the lens of your eye with thick gray mud, obliterating your clear sight. Instinctively, you might blink several times or perhaps rub the affected eye, and then, remarkably, within a matter of seconds or at most a minute, your vision inexplicably returns to normal. In the aftermath, it is common to attribute this strange episode to something innocuous, perhaps standing up too quickly or spending too much time staring at a screen. However, the reality behind this fleeting blindness is far more serious and medically significant. In virtually all such cases, that curtain of darkness is caused by a tiny blood clot or a small fragment of atherosclerotic plaque that has broken away from the wall of your carotid artery in the neck. This microscopic piece of debris then travels upwards through the bloodstream and briefly lodges in the delicate artery that supplies blood to your eye. It is crucial to understand that the artery feeding your eye is not a random, isolated tube. It is a direct and integral branch of the inner carotid artery, the very same artery that is responsible for supplying a large portion of your brain with blood. When that clot or plaque fragment momentarily wedges itself into the tiny eye artery, blood flow is critically interrupted. Consequently, the retina, the light-sensing tissue at the back of your eye, temporarily loses its vital blood supply. This deprivation of oxygen and nutrients is what causes you to experience the sensation of darkness or a blurry smear instead of a clear, coherent image. When the clot eventually drifts away or the artery wall relaxes, blood flow is promptly restored and your vision returns, often leaving you with a profound sense of relief, a feeling of having been incredibly lucky. And indeed, you were lucky, extraordinarily so, because that exact same clot, that same tiny fragment of plaque, could have just as easily traveled a mere 2 millimeters further into a brain artery. Had it done so instead of a temporary 1-minute blackout in one eye, you would likely be facing the terrifying reality of permanent loss of speech, paralysis affecting an arm and a leg, or even death. Medical professionals have a classic Latin term for this singular type of one-eye blackout, amaurosis fugax, which literally translates to fleeting blindness. Neurologists, trained to recognize these critical signals, interpret any description of such an episode as an urgent fire alarm. If a patient reports an experience consistent with amaurosis fugax, they are immediately directed for urgent evaluation because the risk of a real, devastating stroke occurring within the next few hours is alarmingly high. Hospital records frequently reveal a tragic pattern where individuals ignore 2 or 3 of these seemingly minor eye episodes, only for the very next one to lead to a major permanent stroke event in the brain. The second critical warning warning sign that demands immediate attention is a sudden onset of numbness or tingling sensation affecting one side of your body. The precise medical term for this phenomenon is paresthesia, but for practical understanding, you can envision it as your skin behaving erratically, almost acting drunk. This peculiar sensation can manifest in various ways. It might affect an entire arm, or perhaps just the hand or half of your face, or even extend to one complete side of your body. The feeling is often described as pins and needles, a sensation akin to cotton wool or rubbery detachment, or a profound dullness, as if the affected body part has suddenly lost its normal tactile sensitivity. The crucial distinguishing characteristic of this warning sign is its spontaneous appearance. It comes out of nowhere while you are engaged in completely ordinary activities, such as sitting, walking, or simply talking. It then persists for a few minutes before vanishing completely on its own. It is important to differentiate this from common experiences. For example, most people have at some point slept awkwardly on an arm, causing nerve compression that results in temporary numbness, which quickly resolves once you move and restore normal blood flow. That type of numbness is distinctly different. In those instances, your brain and spinal cord are functioning perfectly normally. The issue is a temporary mechanical compression of a peripheral nerve. As soon as blood flow and proper body position are restored, sensation typically returns within a minute or two. In contrast, with a TIA, the underlying problem is not in the arm or the peripheral nerve itself. Rather, it originates in the specific area of the brain responsible for processing sensation from that particular arm or body part. Moreover, a TIA-related numbness episode has absolutely no connection to your posture or body position. Another key piece of information worth noting is that stroke symptoms are overwhelmingly one-sided. This is because each hemisphere of your brain, the left and the right, fundamentally controls and processes sensation from the opposite side of your body. Therefore, if both hands go numb simultaneously and symmetrically, that pattern is more likely to point towards issues with your cervical spine, neck, or other systemic conditions. However, a sudden, inexplicable, one-sided numbness that resolves itself after just a few minutes is an extremely strong indicator that warrants immediate medical evaluation for a possible TIA and a comprehensive assessment of your stroke risk. The third significant warning sign is a sudden and unexplained loss of coordination. This is often vividly described by individuals as experiencing a drunk walk despite having consumed no alcohol whatsoever. You might be walking on a perfectly flat, familiar surface within your own home, and entirely out of nowhere, your foot lands in an unexpected or incorrect place. Your leg might feel inexplicably weak or rubbery, or you could find yourself momentarily staggering into a nearby wall or piece of furniture. Alternatively, you might be suddenly overwhelmed by an intense, violent spinning sensation, a profound vertigo that forces you to instinctively grab onto a chair or a door frame for support. This happens even though you haven't been physically spinning, haven't jerked your head suddenly, and haven't just quickly stood up from bed. All common triggers for more benign forms of dizziness. The part of your brain that is primarily responsible for maintaining your balance and coordinating smooth, precise movements is called the cerebellum. This remarkable structure is situated low in the back of your skull, often analogized as a small extra brain due to its distinct appearance and critical function. The cerebellum is constantly engaged in intricate calculations, assessing your body's precise position in three-dimensional space and determining how forcefully each muscle needs to contract to ensure you walk in a straight line, maintain your posture, and execute fluid actions, rather than stumbling or zigzagging uncontrollably. The cerebellum receives its vital blood supply from a specific network of arteries that ascend through the intricate bone structures of your neck and then branch into the back of your head. This crucial circulatory pathway is known to medical professionals as the vertebrobasilar system. If, for any reason, the blood flow within these arteries drops sharply, even for a mere few Seconds, the cerebellum essentially experiences a glitch or a temporary malfunction due to the sudden deprivation of oxygen and nutrients. This transient impairment is precisely when you might suddenly veer off course, misstep unexpectedly, or feel an intense, disorienting dizziness without any apparent external cause. In everyday clinical practice, a concerning pattern frequently emerges. Individuals often dismiss these episodes, attributing them to trivial factors such as bad shoes, I was just tired, or it must be my blood pressure. Tragically, they only discover much later that these seemingly innocuous events were, in fact, cerebellar transient ischemic attacks, critical warnings from their brain. It is important to distinguish this from benign positional vertigo, BPV, or other common forms of dizziness, which usually have a clear and identifiable trigger, such as rolling over in bed, rapidly turning the head, or a pre-existing inner ear condition. In contrast, any spontaneous, intensely disruptive dizziness, especially when coupled with new difficulties in walking straight or maintaining balance, should be treated with utmost seriousness and regarded as a potential TIA until a medical doctor can thoroughly investigate and definitively rule out a vascular blood vessel cause. The fourth crucial warning sign manifests in your speech, and it is important to be absolutely clear about what constitutes a genuine concern. Occasional difficulty recalling your neighbor's name or momentarily forgetting a common word like toothbrush is not in itself a sign of stroke. These are perfectly normal, tip-of-the-tongue moments, which tend to occur more frequently when you are feeling tired, stressed, or distracted. What genuinely alarms neurologists, however, is something fundamentally different. When your ability to speak suddenly and profoundly breaks down, to such an extent that even you can clearly sense that something is gravely wrong, something far beyond simple forgetfulness. In most individuals, there are two primary speech centers located in the brain, both typically situated in the left hemisphere. One of these vital areas, often referred to as Broca's area, is instrumental in helping you form words, construct coherent sentences, and send precise, clear instructions to the intricate muscles of your tongue, lips, and jaw that enable articulation. When this particular region experiences a critical loss of blood flow, you might perfectly understand everything that other people are saying, and you will know precisely what you want to communicate in response, but you will find yourself tragically unable to get the words out. Your speech may emerge as slurred, choppy, or entirely stuck, or you might struggle intensely to find the right words, even though they are conceptually present in your mind. The other crucial speech area, commonly known as Wernicke's area, plays a different but equally vital role. It primarily assists you in understanding spoken language and in organizing your own thoughts into sentences that are logically coherent and make sense to others. When this specific zone of the brain is experiencing a problem due to interrupted blood flow, a person may still be able to speak with apparent fluency, but the words they produce might form a word salad, a string of grammatically correct but utterly nonsensical phrases or sentences that bear no relation to the conversation. Furthermore, they may struggle profoundly to comprehend even simple phrases or instructions directed at them. If either of these types of speech problems, the inability to produce words clearly or coherently, or the inability to understand speech and construct meaningful sentences, suddenly appears, and then, after a few minutes, completely fades away, this is a classic presentation of a transient ischemic attack, TIA. It is emphatically not simply a case of being just tired. It is a grave error to ignore suddenly broken speech, merely because it seems to have self-corrected. Such dismissal is akin to your home alarm system blaring loudly, then inexplicably stopping on its own, and you casually deciding that it was probably nothing to worry about. The temporary resolution of the symptom does not negate its profound significance as a warning. The fifth and final warning sign is often less obvious than the others, and can come as a surprise to many. It involves a specific combination of certain skin changes, coupled with the development of new, unusual unusually strong headaches that deviate from any prior headache patterns. The particular skin condition implicated here is vitiligo. Vitiligo manifests as distinct patches of pale or entirely white skin, areas where the pigment-producing cells, called melanocytes, have ceased to function effectively. This condition is fundamentally an autoimmune process, meaning that the body's own immune system, for reasons not fully understood, mistakenly begins to attack and destroy its own pigment cells, erroneously perceiving them as foreign invaders. A crucial point to understand about autoimmune diseases is that when the immune system goes off target and starts attacking the body's own tissues, it frequently does not limit its assault to a single organ or system. In a significant number of individuals with vitiligo, that very same underlying autoimmune process can silently and insidiously inflame the inner lining of blood vessels throughout the body. This incredibly delicate inner lining is called the endothelium, a microscopically thin layer of specialized cells that coats the inside of every artery, much like a super smooth non-stick surface in a high-performance cooking pan. When the endothelium is healthy and intact, blood components, including cholesterol and platelets, glide smoothly past without adhering. It acts as a protective barrier. However, when this vital lining is damaged by chronic inflammation, it becomes rough, scarred, and begins to lose its crucial non-stick properties. This altered surface then becomes a perfect landing pad for various substances in the blood. Cholesterol, particularly low-density lipoproteins or bad cholesterol, platelets, and a range of inflammatory proteins. Over time, these deposits gradually accumulate and grow, forming the seeds of atherosclerotic plaques and blood clots. While vitiligo alone certainly does not automatically condemn an individual to a stroke, if, on top of having vitiligo, a person begins to experience frequent, unusually intense headaches that do not conform to their typical headache patterns, this specific combination is a significant red flag. This particular pairing of symptoms warrants a thorough and proper vascular workup by a medical professional, rather than a passive wait-and-see approach. Headaches in general are notoriously tricky to diagnose because many people mistakenly blame them on underlying vascular issues when the true problem lies elsewhere. A very common source of daily or frequent head pain, for instance, is the wear and tear, arthritis, in the small facet joints located between the second and third vertebrae in the neck. This degeneration can irritate nearby nerves, sending referred pain upwards into the head, a phenomenon that has absolutely nothing to do with a blocked brain artery. Furthermore, many individuals unknowingly carry an undiagnosed herniated disc in their neck, and if left unaddressed, in severe cases, it can threaten the nerve supply to the arms or legs. Headaches should never be merely numbed with long-term pill use. They require careful investigation and decoding by a doctor, especially when their character changes. They become more frequent, or, crucially, when they appear in conjunction with other warning signs, such as the ones we have just discussed. Now let's turn our attention to the fundamental processes that truly wreak havoc on your blood vessels from the inside, often in ways that are misunderstood. This is where one of the most pervasive myths about stroke risk deeply resides. The myth, often repeated and widely believed, is this: my cholesterol is normal, so I am completely safe from stroke. While cholesterol levels are indeed a component of vascular health, they represent only one piece of a much larger, more complex puzzle. Stroke risk is not solely about the concentration of various substances floating freely in your bloodstream. Critically, it is very much about the actual condition of that endothelial lining, that super smooth non-stick surface on the inside of your blood vessels that we discussed earlier. Let's revisit the analogy of the non-stick cooking pan. As long as the non-stick coating remains perfectly intact and undamaged, food slides off effortlessly and nothing clings. However, the moment that coating is scratched, damaged, or compromised, everything begins to stick, burn, and build up. Your endothelium functions in much the same way. The first major enemy of this delicate endothelial lining is chronically elevated blood sugar levels. Glucose, or sugar, is indeed the essential fuel for all your body's cells. However, for glucose to move from your bloodstream into the endothelial cells and other cells, it requires the presence of insulin, a hormone that effectively acts as a key, opening the door into the cell when your body either fails to produce a sufficient amount of insulin or when your cells, including the endothelial cells, become resistant to its effects, a common precursor to type 2 diabetes. You can have an abundance of sugar circulating in your blood, yet paradoxically, the cells lining your vessels are essentially starving. Starving cells become damaged, lose their normal shape and function, and can even begin to peel away from the inner surface of the artery, leaving behind rough, irregular, and scar-like patches. These damaged and scarred zones are no longer capable of contracting or relaxing properly in response to changes in blood pressure. Medical professionals refer to this as a loss of vasomotor reserve, signifying that the vessel has lost its crucial flexibility and responsiveness. Furthermore, these rough, damaged spots create perfect landing pads for bad cholesterol, specifically low-density lipoproteins, LDL, along with platelets and other blood components. Over extended periods, these deposits progressively grow and accumulate, ultimately forming the dense, rigid plaques that narrow and stiffen your arteries, setting the stage for ischemic stroke. This insidious process often begins silently, years before anyone officially diagnoses you with diabetes. Even mild prediabetes, where your blood glucose levels are only slightly above the normal range, is sufficient to initiate and sustain this quiet injury to the endothelium over a long duration, making early detection and intervention critical. The second formidable vascular enemy, one that directly assaults the integrity of your blood vessels, is smoking. Cigarette smoke is a highly complex chemical cocktail, containing thousands of distinct chemical compounds, dozens of which are unequivocally identified as cancer-causing substances. However, when considering the risk of stroke, the primary concern revolves specifically around the detrimental effects of these toxic compounds on both the endothelium and the properties of the blood itself. With every single cigarette inhaled, the myriad toxic compounds present in the smoke directly impact the inner surface of your blood vessels, inflicting immediate chemical damage and triggering an inflammatory response. Simultaneously, the nicotine and carbon monoxide contained in cigarette smoke work together to make your blood thicker and stickier. This increased viscosity and stickiness significantly heightens the ease with which platelets clump together and how readily blood clots form. When you combine a damaged, inflamed, and roughened vessel wall with blood that is thicker and more prone to clotting, you create an almost ideal environment for a blood clot to form and ultimately plug a vital brain artery. This is precisely why individuals who smoke have an astonishingly elevated risk, roughly 2 to 4 times higher, of experiencing an ischemic stroke compared to non-smokers, even when other risk factors like cholesterol levels and blood pressure numbers are comparable. The impact of smoking is a direct, undeniable, and dose-dependent assault on your vascular system. Blood pressure introduces yet another layer of potential confusion because the prevailing myth surrounding it often runs in the opposite direction. Many people have assimilated the knowledge that stroke is associated with high blood pressure, and as a result, they are acutely terrified of a high blood pressure reading, often feeling a sense of relief when their pressure is measured as low or within the normal range. While it is undeniably true that chronically elevated blood pressure or hypertension is absolutely one of the strongest and most significant risk factors for stroke, this is because, over many years, it physically stresses, stretches, and weakens the delicate vessel walls, accelerating the formation of arterial plaque. Indeed, it is the primary driving force behind hemorrhagic strokes, where the relentless pressure literally causes a vessel to burst. However, there is a crucial twist to this understanding, particularly concerning ischemic strokes. An ischemic stroke, the type caused by a blockage, very often occurs not at the peak of an individual's blood pressure, but rather at a relative low point in their pressure cycle. To illustrate this, envision a brain artery that has already been significantly narrowed, perhaps by more than half, due to the presence of an atherosclerotic plaque. It is akin to a garden hose or water pipe that someone has constricted or squeezed tightly in the middle. As long as the overall pressure within the circulatory system remains sufficiently high, some water will still manage to squeeze through that tightened segment, albeit with difficulty. However, if the overall systemic pressure suddenly falls, the flow of blood through that severely narrowed point can plummet to almost zero. This risk is compounded if a small clot happens to get stuck at that already constricted site and the diminished systemic pressure lacks the necessary push to dislodge and move it along. At night, during the crucial hours of sleep, your blood pressure naturally undergoes a physiological dip, typically falling by approximately 15 to 20%. This is a completely normal, healthy physiological adjustment, not an indication of disease. However, if you already possess an artery that is significantly narrowed by plaque, this normal nighttime drop in blood pressure can be precisely enough to transform a partial blockage into a complete cessation of blood flow. This risk is particularly heightened if a small clot has already formed on the surface of that plaque while you were lying quietly in bed. This physiological phenomenon is one of the primary reasons why some individuals go to bed feeling perfectly fine and then awaken in the morning with unmistakable stroke symptoms, or why they are tragically discovered in this state by others. Age, of course, plays a role in stroke risk, but not in the overly simplistic and often misleading way you might hear at family gatherings, where stroke is relegated exclusively to old people. While it is true that stroke risk rises significantly after the age of approximately 50 and roughly doubles with each successive decade of life, the causes and presentations can differ. In older adults, the dominant underlying causes tend to be widespread atherosclerosis, plaque buildup, coupled with long-standing high blood pressure and various heart rhythm problems, particularly atrial fibrillation. However, it is a significant and often overlooked fact that about 10 to 15% of all strokes occur in individuals younger than 45. In these younger patients, hospital records and medical studies reveal a different set of primary drivers: congenital vessel abnormalities, bulging weak spots, in vessel walls known as aneurysms that can rupture, inherited or acquired clotting disorders, specific autoimmune diseases, and physical trauma to the head or neck. Another crucial aspect worth fully grasping is that the speed of vascular damage resulting from the same established risk factors changes significantly with age. After the age of approximately 40, the rate at which plaque buildup occurs and endothelial injury progresses from factors like smoking, elevated blood sugar, or high blood pressure tends to accelerate to about twice the rate observed in your 30s. This acceleration in vascular damage is a compelling reason why doctors become more direct, proactive, and insistent about rigorous risk factor control as patients progress through their 40s and 50s. Therefore, consider this question: how old are you right now? Your current age fundamentally influences how quickly your blood vessels respond to these common risk factors, and also shifts the likelihood of which specific causes of stroke are more pertinent to your individual situation. This personalized understanding is profoundly important in guiding what you and your doctor should be meticulously paying attention to in terms of prevention and early detection. Now, let's transition to the most practical and immediate part of this discussion. What precisely should you do if you have already experienced even one of those 5 critical warning episodes, regardless of how minor it felt or how quickly it vanished in under 10 minutes? It is imperative to remember that you have approximately 72 crucial hours, a vital window of opportunity, during which a great deal can still be done to prevent a full-blown, devastating stroke. The primary goal is not to succumb to panic, but critically, it is also not to waste this precious window of time. Stroke specialists consistently emphasize the profound importance of not being completely alone in the immediate aftermath of a suspected transient ischemic attack, TIA. This aspect is genuinely worth proactively planning ahead with your family and your doctor, particularly if you happen to live by yourself. If, God forbid, another more serious episode were to occur and you suddenly found yourself unable to speak or move, you would urgently need another person present who can clearly recognize what is happening, immediately call emergency services, and reach you quickly to facilitate essential care. Many individuals find it incredibly helpful and reassuring to explicitly inform a close family member or friend about what occurred and to ensure that someone reliable can easily reach them over the course of the next couple of days. This is an entirely reasonable and prudent matter to discuss with your healthcare provider. Furthermore, established stroke guidelines strongly advise against driving yourself after experiencing a possible TIA. Losing your vision or control of an arm for even a few terrifying seconds while driving at highway speeds constitutes a life-threatening risk, not only to yourself, but also to every other person on the road around you. It is undeniably worthwhile to discuss a comprehensive transportation plan with your doctor in advance, outlining what course of action makes the most sense in your specific situation should something like this ever happen, thereby removing any temptation to simply drive yourself to a clinic or hospital. Checking blood pressure is almost invariably among the very first diagnostic steps in virtually any acute medical situation, especially when a stroke is suspected. If you or someone nearby can accurately measure your blood pressure, pay close attention to the readings. If the top number, the systolic pressure, is around 180 mmHg or higher, and the bottom number, the diastolic pressure, is around 110 mmHg or higher, this clinical picture strongly aligns with a hypertensive crisis, which is far more serious than just merely elevated blood pressure. A crisis of this magnitude is, in itself, a potent and urgent warning sign for an imminent stroke. In such a scenario, calling emergency services immediately is precisely what standard medical guidelines frequently recommend. It is prudent to ask your doctor explicitly about these specific blood pressure thresholds during a routine visit, so you are well informed in advance about when to unequivocally treat such a reading as an emergency. One rule stemming from the extensive body of stroke medicine is absolutely strict and inviolable. Never, under any circumstances, initiate blood-thinning drugs such as aspirin, prescription anticoagulants, or similar medications on your own, based solely on a friend's advice, something you read online, or personal intuition. The reason for this rigidity is critical. As we discussed, there are two primary types of stroke: ischemic, where a blood vessel is blocked by a clot, and hemorrhagic, where a blood vessel is actively bleeding into the brain. While thinning the blood can be immensely beneficial and even life-saving in specific ischemic situations by helping to dissolve or prevent clots, in the case of a hemorrhagic stroke, thinning the blood can catastrophically exacerbate the bleeding, making it faster and larger, which can tragically accelerate mortality. The only reliable way to differentiate between these two types of stroke with certainty is through rapid brain imaging, most commonly a CT scan performed in a hospital setting. No doctor, regardless of their experience, can definitively look at a person and be 100% certain which type of stroke is occurring without the crucial diagnostic information provided by a brain scan. Therefore, instead of attempting to self-treat, which carries immense risks, the unequivocally correct course of action is to seek immediate medical evaluation and allow a qualified medical team to perform the necessary diagnostics and make informed treatment decisions. You can, and indeed should, absolutely ask your doctor in advance how they would prefer you to act if you ever suspect a stroke, while waiting for emergency medical help to arrive, or while en route to a care facility. The position of the body can matter significantly. Generally speaking, lying down flat is considered better than sitting bolt upright because it facilitates better blood flow to the brain, which is desperately needed during a potential stroke. Many experienced clinicians suggest a comfortable, flat position with the legs gently raised slightly above chest level. This posture can help support overall circulation back to the heart and ease the heart's workload. The head should be maintained in a neutral position, neither bent sharply forward nor thrown back, to ensure that the vital neck vessels, which carry blood to the brain, are not kinked or compressed. Furthermore, it is wise to avoid smoking, consuming alcohol, or exposing oneself to hot baths or very hot showers during such a critical moment. Sudden and significant vessel dilation that can be induced by these activities in an already unstable circulatory system has the potential to dangerously worsen the situation. Always double-check these specific recommendations with your own treating doctor, as individual circumstances can vary. A seemingly small, but potentially life-saving step is to keep a meticulously written list of all the medications you take regularly, including dosages, somewhere easily accessible and findable, perhaps in your wallet or on your refrigerator. This simple measure can save precious minutes for emergency medical teams, enabling them to quickly understand your medical profile upon arrival. Something many people misunderstand is the implication of time passing after a warning episode. If 72 hours pass after a suspected TIA and no new, more serious episode occurs, that absolutely does not mean you are entirely in the clear. What it signifies, rather, is that you have been granted an invaluable second chance, and it is crucial that you still utilize it proactively. There are 3 specific medical evaluations that are highly reasonable to inquire about during your next medical visit if you have experienced any of the warning signs we have discussed. Each of these tests provides unique and vital insights into different pieces of the complex stroke puzzle. The first essential evaluation is a specialized ultrasound of your neck arteries, known as a carotid duplex ultrasound. Unlike a basic ultrasound that simply provides a static image of anatomical structures, duplex imaging is sophisticated enough to display both the precise anatomy of the carotid artery and, critically, how blood is actively flowing through it. This includes detecting whether the blood flow is speeding up and becoming turbulent at a segment where the artery might be narrowed by plaque. If the carotid artery is found to be narrowed by more than approximately 70% due to plaque buildup, medical professionals classify this as a hemodynamically significant stenosis. This technical term indicates that the narrowing is severe enough to seriously impair vital blood flow to the brain. At this critical juncture, the question shifts from will a stroke ever happen to when will it happen if nothing changes? This urgent prognosis is why surgeons may recommend a procedure called carotid endarterectomy. During this surgery, they carefully open the artery and meticulously remove the obstructing plaque. While the thought of brain surgery might sound dramatic or daunting, in modern medical practice, carotid endarterectomy is a routine and highly effective surgical procedure that successfully saves tens of thousands of individuals from debilitating strokes every single year. Therefore, if you possess any of the identified stroke risk factors or have experienced any of the warning symptoms, initiating a conversation with your doctor about undergoing a carotid ultrasound is an eminently reasonable and potentially life-saving step. The second crucial test is a simple blood test known as glycated hemoglobin, often referred to by its abbreviation HbA1c. This test measures ordinary hemoglobin, the vital oxygen-carrying protein found within your red blood cells that has had sugar molecules, glucose, chemically bonded or stuck to it. The principle is straightforward. The higher your average blood sugar levels have been over the preceding months, the greater the proportion of your hemoglobin that becomes sugar-coated. This is why the HbA1c test provides an accurate reflection of your average blood sugar levels over a period of approximately 3 months, offering a much more comprehensive picture than just a single morning snapshot provided by a fasting glucose test. You cannot game a good HbA1c result by simply adhering to a perfect diet and exercise regimen for just 1 day before the blood draw. It reflects the long-term trend. This test is particularly effective at identifying that crucial gray zone known as prediabetes, a state where blood sugar levels have been elevated enough for a sufficient duration to cause damage to blood vessels, yet no official diagnosis of diabetes has yet been made. The diagnostic cutoffs for glycated hemoglobin are clear and well-defined. An HbA1c reading under approximately 5.7% is considered normal. A range between 5.7% and 6.4% indicates prediabetes, and a reading of 6.5% or higher typically confirms a diagnosis of diabetes. If you have never had this important test performed, or if it has been several years since your last one, bringing it up with your doctor is an easy yet profoundly important step, especially if you have any existing stroke risk factors. The third vital investigation is Holter monitoring of the electrocardiogram, ECG. In plain terms, this involves a continuous 24-hour recording of your heart's electrical rhythm. Instead of the brief 10 or 20-second snapshot of your heart's activity obtained during a standard electrocardiogram in a clinic, you wear a small, portable device for an entire day while going about your normal daily routine, allowing for a prolonged and comprehensive recording. The rationale behind this extended monitoring is straightforward yet critical. Some dangerous heart rhythm problems are intermittent. They come and go. They might only show up once or twice a day, lasting for just a few seconds, and would therefore be completely missed by a short, standard snapshot ECG. The single biggest rhythm culprit for causing stroke is a condition known as atrial fibrillation, often abbreviated as AFib. In atrial fibrillation, the two upper chambers of the heart, called the atria, cease to beat in a steady, organized, and coordinated manner. Instead, they quiver chaotically and irregularly, sometimes at astonishingly rapid rates of 300 to 400 contractions per minute. When this disorganized quivering occurs, blood does not empty smoothly and efficiently from the atria. Instead, it churns and swirls within these chambers. In this turbulent, swirling blood, clots form very easily and frequently. These dangerous clots can then be propelled out of the heart, travel upwards through the bloodstream to the brain, and ultimately lodge in a vital brain artery, causing an ischemic stroke. This particular type of stroke, known as a cardioembolic stroke, tends to be particularly severe due to the size and origin of the clots. Many individuals who suffer from atrial fibrillation do not experience dramatic or debilitating symptoms. At most, they might notice occasional skipped heartbeats, brief flutters in their chest, or they might mistakenly attribute these subtle sensations to stress or excessive caffeine consumption. Holter monitoring is specifically designed to catch these hidden or intermittent episodes of AFib that would otherwise go undetected. If atrial fibrillation is indeed discovered, there are a range of well-studied and highly effective medications, primarily called anticoagulants or blood thinners, that can be prescribed. When these medications are correctly prescribed and meticulously monitored by a healthcare professional, they can dramatically reduce the risk of stroke in individuals with AFib by approximately 60 to 70%. This is not an inevitable outcome. Rather, it represents a significant and actionable risk that you and your cardiologist can actively work on managing and mitigating. Stepping back to gain a broader perspective, it becomes clear that a stroke is not merely a random lightning bolt from a clear sky event. On the contrary, it is, in most cases, a predictable medical occurrence that typically unfolds after years of silent, progressive damage to the blood vessels. And crucially, it often announces itself in advance through subtle yet unmistakable warning signs. You are now equipped with the knowledge of the Big Five, the most critical indicators: brief, temporary blindness in one eye, sudden onset of one-sided numbness or tingling, an abrupt and unexplained loss of coordination, often manifesting as an unsteady or drunk walk, a sudden, serious breakdown in your ability to speak or understand speech, and the specific combination of vitiligo paired with new, unusually intense headaches. Any of these symptoms appearing for the very first time, even if they resolve and vanish within a minute, is a profound reason to seek urgent medical consultation with a doctor. It is essential to explicitly ask about those three vital evaluations: carotid duplex ultrasound to assess neck arteries, glycated hemoglobin HbA1c to gauge long-term blood sugar control, vital, and Holter ECG monitoring to detect intermittent heart rhythm abnormalities. On the proactive prevention side, a wealth of robust medical research consistently links certain lifestyle modifications and medical management strategies to a significantly lower stroke risk. Maintaining blood sugar levels within a healthy range and diligently catching prediabetes at an early stage are paramount for protecting the delicate endothelium, slowing the progressive growth of atherosclerotic plaques, and preserving vascular health. Effectively managing your blood pressure with the expert guidance of your doctor, which means not simply pushing it down at all costs, but carefully avoiding both dangerously high and excessively low extremes, significantly reduces the physical strain on your blood vessels and lowers the risk for both hemorrhagic and ischemic strokes. Quitting smoking, ideally with professional support if you need it, removes a relentless chemical assault on your arteries and can dramatically cut your ischemic stroke risk by a factor of roughly 2 to 4 over time. And perhaps the most important takeaway, the most crucial concept to deeply internalize and act upon is this: do not wait for brief brain symptoms to simply go away by themselves. In the critical world of stroke medicine, you typically have a very narrow window of approximately 72 hours to act decisively. Here is a clear action plan for you to consider after finishing this video. If you recognize any of the 5 warning signs discussed today from your own past experiences, even if they occurred months or years ago, take the time to write them down in plain, descriptive language. Bring this detailed list to your doctor during your next medical appointment. Do not rely solely on memory, which can be fallible under pressure. Ask your doctor directly whether you should be formally evaluated for transient ischemic attacks and whether a carotid ultrasound, glycated hemoglobin test, or Holter monitoring makes clinical sense in your specific case, given your personal history and symptoms. If you have any known stroke risk factors, such as high blood sugar, chronically high blood pressure, a history of smoking, or diagnosed autoimmune conditions, utilize the knowledge you have gained here to engage in a more specific, informed conversation with your doctor about comprehensive stroke prevention strategies, rather than simply accepting a generic "everything looks fine" without actual numbers or a clear plan. Everything we have covered today is solely for your understanding and educational empowerment. Your medical situation is uniquely specific to you, and using this information as a thoughtful starting point for a real, in-depth conversation with your doctor will always be infinitely more useful and beneficial than attempting to manage complex health matters on your own. If this detailed explanation has made a complicated and critically important topic easier to follow and understand, please consider subscribing and tapping the like button. That collective support is how Dr. Waterling gets closer to that important goal of 200,000 subscribers, helping to spread this vital health information further. And for something practical you can keep handy on your phone, remember to scan the QR code that is often displayed on screen to join the Telegram channel, where short checklists and step-by-step health tips are regularly posted, offering further guidance and support.